Dr. Prakhyat Roop from Meerut both have joined here to discuss about iStent experiences they have gone through in last 1 year, 6 months, and they will be sharing their own experience. And here we are going to have the both topic like iStent step execution optimization by Dr. Kaivan sir, and experiences Indian experience with iStent technology, where Dr. Prakhyat sir will be sharing his own experience. So Susil, take the next page. So uh, it is a great opportunity for me to welcome Dr. Kaivan sir in our 16th eConnect iStent Forum. Sir is consultant ophthalmologist in Bhavna Super Speciality Eye Care Hospital in Surat, and sir has completed his MBBS DO in Pram Pramukh Swami Medical College, Karmasan, and FICO from International Council, London. FICO from Glaucoma, and FMRF Glaucoma Fellowship and Advanced Cataract Fellowship in Sankar Netralaya, Chennai. Sir has a keen interest in interventional glaucoma, in MIGS, or, and adult and pediatric glaucoma, as well as the cataract. Sir has done more than 7,000 cataract and glaucoma surgeries, and sir has been for uh, various phase 3 clinical trials as a principal and co-investigator. So welcome, sir. Welcome to our eConnect meeting. And again, I will welcome my second speaker, Dr. Prakhyat Roop, sir. And Susil, can you take that? Yeah. So Dr. Prakhyat, sir, he's a consultant ophthalmologist in Acura Vision Clinic, Meerut. And this center, like Meerut, is nearby to the Delhi of 60 kilometer from Delhi. And sir has done his AMD from New Delhi, AIMS from New Delhi, and sir has a keen interest in cornea, cataract, refractive, and mixed surgeries. And sir has a few major achievements which is really to be mentioned. He's only Indian to won the prestigious ASERS winning pitch challenge twice, and having the 6 granted patents, including 2 in United States of America and Europe. He has led advancement in both monofocal and multifocal IOL technology. His 2024 award-winning ASERS film ND Ring, The Ring of Light, further showcased his inventive device for treating negative dysphotopia. He is also one of the pioneer of clear and cutting-edge lenticle extraction procedure. He is prolific in anterior segment surgeon, and his favorite surgeries are complex anterior segment reconstruction and lamellar corneal transplants such as DMAC. So welcome Dr. Prakhyat Roop sir in our 16th of eConnect iStent Forum. Now I will hand over this session to Dr. Kaivan sir to start his presentation. And meanwhile, from the participant side, if we have any questions, so we can put in our chat box, and we can take these questions after the both presentation. So our both speaker will be comfortably able to answer you after the presentation. Over to you, sir. Susil, guide to sir about just to share.
Dr. Kaivan, can you start sharing your screen and your screen
Yeah,
also?
I'll just start it. Should I?
Susil, can you?
Yeah.
So, is it my screen is visible?
No, so far not.
I'm not sure how to. Okay, now.
See, there is a green button which says share at the center, exactly at the center.
I just tried that, but the window. What I just.
First, you have to switch on your video also. I think your video is off.
Okay.
So at the bottom left, there is audio and video. You turn both of them on and then press share.
Okay.
Yes. I think now you can start sharing.
Yeah. Is it visible now?
Yes.
Yeah, it's very much visible. Good.
So good evening, one and all. I will just share my personal experience regarding the each and every steps of the surgery. I'll just this is basically up to the iStent, but most of the things are will take care of the mix overall mix part also. So hope you'll will learn something. Uh, so when we start any mix procedure, there are multiple issues we come across. So basically, this is a new era of the surgical procedures in the glaucoma spectrum. So many doctors are afraid of to accept the technology sometimes because of the many limitations which are coming with the newer procedures. So basically, how to overcome the critical angle because as we all know. The the mixed procedures are done in the angle in with but the angle is we are not able to see with the naked eye or directly through the microscope because of the phenomenon of the critical angle. So we have to overcome that. How then next is how to overcome the microscope limitations. Many of us are like me. I'm in the private practice. I'm not in the institution practice. So usually we don't have the higher end microscopes like Lumira Eye or like I820 or like something like that. So we should be able to do the procedure with the current setup with some modifications. So we should be able to learn those things. So I'll just share my experience along with that also. Then once we have focus on the angle, how to identify the trabecular meshwork, especially in the very lightly pigmented meshworks. So another question arises how to maintain the chamber and the angle depth throughout the surgery because frequently the visco comes out and our focus does not allow us to go further. And finally, how to implant the stent perfectly. So let's take a deep dive into the basics of each steps and optimize the implantation. First of all, any surgery starts with the anesthesia part. Usually, most of the procedures nowadays are we are doing under topical anesthesia. But this is the thing when we start any mixed procedure. So the it is done under very high magnification. So usually the focus, if there is a movements of the eye of the patient on in the under topical anesthesia, our focus suddenly gets blurred. So good akinase is very crucial when working on high magnification. Even a small saccadic eye movements create frequent blurring of the angle structures. The another part is whenever there is micro movements or saccadic movements, there may be inadvertent touch of the meshwork with the trocar tip, or if you are doing some blade procedures, then the tip of the needle or the KDB can induce bleeding and which can hamper the clarity. Nevertheless, it can be performed under topical anesthesia with the experience. But initially, at least, we prefer peribulbar anesthesia. So that will help us a lot during the surgery for the proper focusing. Second is surgical site preparation. These are the very small things, but sometimes you get a very clear view if you take care of these small things, like of washing conjunctival just sac thoroughly, because there are many times we see that the mebum is there in the sac, which comes in the surgical site and block the view, or just it becomes hazy. So we should thoroughly clear all the debris or any particles or any mucus before proceeding. And good draping is very important because in this case we are putting some lens on the cornea, so it should not get fogged. The third important thing is wound construction. Usually, we need two clear corneal side ports for a standalone mixed procedure. With we can do with the 20 gauge MVR blade, or we can do with the 15-degree blade also. Usually, the first will be at the 0 to 180 degree depending on the eye, and second will be 2 to 3 clock hour left or right depending on the eye and the dexterity of the surgeon. Like I'm a left-handed surgeon, so I usually keep my the second side port towards my left. So the size of these ports is very important actually, because this much size allows easy manipulation of the injector as well as it prevents the excessive OVD loss. So it helps maintaining the chamber throughout the surgery. The second important thing is you should avoid the limbal vessels to prevent the bleed. So these things we can will see in the videos also later on. So, but you have to remember that the moment you touch the limbal vessels, it will start oozing, and those blood can come in the interface between the lens and the cornea and obscure view, and avoid two anterior corneal entry also. You should remain in between to remain the parallel to the iris and not touching the gonium. Otherwise, what happens that the prism, the border of the prism will be touching to the injector. Now, the most important thing is the visualization. So in this case, we have to get the en-face view, and the idea is to overcome the critical angle of the cornea to view the angle structures wide and very crisp. So you need two things basically: tiltable microscope and obviously tilted head of the patient. If there is some issue with the neck or the patient is not able to turn the head, so it is very difficult for the proper visualization of the angle. And you need a good gonio lens, surgical gonio lens. These are the direct gonio lens, not like an indirect one. So you directly see the angle and do the procedure. Keep the small tip is whenever you tell the patient to their head to the opposite side, ask them to rest their earlobe, opposite earlobe, and after that you can adjust the eye gaze to get the best view. You should always check the microscope tilt first. So my microscope, I am using Leica 620. So my microscope does not allow rotation beyond 7 degrees. So I have to compensate those extra degrees with the patient's head rotation. So if your microscope allows 30 to 35 degree tilt, like in a Zeiss Lumira eye or the like a higher end one, the head should be rotated around 30 degree to the opposite side. If less than that, you have to compensate it with the head rotation. After the microscope tilt, you should adjust the eyepiece as per your comfort, height, and as per your height and comfort. So as you can all see, this is my microscope position after 7 degree tilt. So this is the primary position, and this is after tilting off. So there is only 8 degree of tilt you can see. So I have to compensate the head of the patient for this microscope limitation. So in this, the second image, it is a zoom image. You can see the position of my the handle of my lens. So that is exactly in alignment with the eye, and this is the vertical primary position. So that is coming around 56 degree. So you can see that there are some ergonomic limitations in this position, because your the dominant hand will remain very perpendicular to the surface, and your non-dominant hand, we cannot leave the gonio lens like they are saying in the eye prism ethics, that you can always leave it will stay in this position. It will not stay because it is quite a bit rotated 56 degree from the vertical. So you have to definitely hold this thing with your other dominant non-dominant hand. Then the small things are always use cohesive OVD. 1.8% is better than 1.4% sodium hyaluronate on the cornea and to fill the AC. Put a direct gonio lens. Use any prism lens whichever you're comfortable. I usually do with eye prism or a catena and view the angle. Avoid this is a very small things I usually noted during my initial surgeries, that there were unwanted light reflections from the lens surface. So in that case, it obscured the view, and you are not sure like whether you are touching the TM, but sometimes the reflex comes and your view does not get clear. So usually I switch off all the room lights. So apart from microscope light, no other reflection from the lens can occur. You can always put some viscoelastic, like a viscomet on the gonio lens. It improvise the visualization by coating the lens surface, and it gives some extra magnification also. Check the lens cornea interface for any blood or air bubble. So whenever you put any lens on the cornea, there may be some the oozing from the side port, or as we discussed earlier, or some air bubbles can come and obscure your view. So you just have to check that thing also. And always after getting the position, always manipulate the lens or manipulate the eye to get the proper view. The visualization is very important. So you have to give some extra time before starting the procedure. You have to give the extra time for proper visualization. Check proper widening of the angle. So if you feel that you are not able to see the mesh-up throughout or the other structures in the angle, fill some extra OVDs in the angle so that it will push the iris backwards, and you can see, you can visualize the angle from scleral spur to the iris root. So that is very important. At this optimum magnification, usually in the cataract surgery, we usually operate around 8 to 10 times magnification. 10 times is the max usually we use. But in this case, you have to do extra magnification because of the TM is a very only 350 micron height. So in that case, you have to be very precise, and you have to be the view will be very crisp. Apply very light pressure on the gonial prism, avoiding corneal stripe. If you pressurize your lens, the cornea will show some stripe, and it will also visualize obscure the visualization. The next important thing is after the focusing on the angle, the trabecular meshwork identification. So as we all know, all the angle structures from anterior to posterior. So usually these procedures we try to do at the junction of anterior non-pigmented meshwork and the posterior trabecular pigmented meshwork. You can sometimes in the very lightly pigmented meshworks, you can create hypotony initially. The hypotony will cause the retrograde flow of the blood in the Schlemm's canal from the epicondral veins. So it will feel that the Schlemm's canal and improvise the TM visualization. You can try scleral indentation also, that I will demonstrate in the later videos. You should identify the structures from anterior to posterior and then finalize the location. Aim for the darker pigmented trabecular meshwork always for the stent placement, because it is suggestive of a collector channels result, more number of collector channels resulting in a good outflow. So that you have to take care. If you find patchy TM, and so in that case you can put the implant the lens where the TM is more dark. So in that case, the outcome will be we can expect a good outcome. So in this case, you can see this patchy TM. Here the meshwork is good pigmented. Here also the pigmentation is good. In between it is very light. So I'm not sure whether you can see this stent here. This was the G1 done 1.5 years back. So we implanted exactly in that intranasal patchy meshwork. Now we come to the iStent implantation. Uh, you should hold the injector between the thumb and the middle finger, leaving the index finger free for the movement of the insertion sleeve. Uh, move the insertion sleeve retraction button back and forth to loosen it before entering the AC. You can always see the blue retraction sleeve button. You always loosen that first. Otherwise, if it is hard, then it is difficult when you are inside under high magnification. It is difficult to control that thing. You should always enter with the sleeve on. Retract only after crossing the pupillary margin to expose the trocar. So if you enter with the trocar exposed, there are two things. Trocar can damage the surrounding structure. It's a very sharp thing. So it can pierce the cornea also. And the second thing, the trocar is very thin, so it can get damaged also. And the alignment of the trocar can get disturbed. Adjust the injector angle, avoiding pressure on the incision. So whenever you are you should aim for the perpendicular entry in the to the trabecular meshwork. So always that angle has to be precise, but at the same time you should avoid the pressure on the posterior lip of the incision to so that the chamber remains stable. Check for the trocar bias before firing. So sometimes in the early injectors, there were no side windows. So sometimes the trocar bias was a problem. Nowadays with the Inject W, we can see the whether trocar is going left or right. So we can just check for that first. Then you fire and remain perpendicular to the trabecular meshwork. Always pierce the meshwork first. Gently touch the sleeve and fire. Hold. You should hold for a few seconds before releasing that fire button, and then you release slowly. So basically, it helps the meshwork on the firm. It will firmly get the meshwork will firmly get attached on the stent body, and it will not allow the stent to fall back in the AC. Sometimes the stents can come with a trocar when you release prematurely, so that we have to avoid. And always you should remember that we get only 4 clicks, so each and every click is very very important. So always fire only when you are 100% sure that it is going to go in the meshwork, not anywhere else, and you keep holding for few seconds before releasing that thing. Always cover up trocar with sleeve before the exit. The same concept when we are injecting, the same thing you have to when you are exiting. You have to remember that thing. It will protect the trocar. It will and the remaining eye stents also, and it will prevent the damage to the surrounding eye structures. Always you can reposition the chair and the microscope if required for the second stent placement, and keep always at least 3 clock hour distance between the two stents. After the implantation, you should observe both the stents for proper placement. You should see you should always do a procedure check. It will confirm the stent fixation. You should just see whether the stents are not getting loose with the. You can just touch with the visco cannula and just see whether the stents are properly fixating in the meshwork or not. And you can see the blood oozing from the trocar. Then it confirms the proper placement. And if found loose, then you should do a rethreading of the trocar either inside the eye, or you can just with the micro forceps you can gently keep pull out the stents and rethreading under the microscope outside the eye, and then reimplant that stent. Always check for double stacking and under implantation. Double stacking is whenever you have fired one stent, but it has remained on the trocar, and you are piercing in the trabecular meshwork along with in the deep in the trabecular meshwork, and you again fire. Then what happens that the trailing the trailing stent will push the first stent further deep in that meshwork, and both the stents will go in one shot at one place. You can just check that under microscope inside the eye also. You'll not find a single stent on the trocar. Both the stents are inside the meshwork, so then you are helpless. You cannot remove that stent and again one stent and again implant to the other side. And always prevent under implantation also. That will keep the stent loose, and you have to rethread and again reimplant. The blood reflux is a good sign, and do always a proper visco wash at the end to prevent the IOP spikes post-op, because remember we are using 1.8%, which is a very high molecular weight. So if even if we keep some this high molecular weight visco, it will give a bad IOP spike later on. So moving to my surgical videos, this was my first stent with the G1. So basically, I want to just share with my visualization and the implantation. So once we do the side port entry, we form the AC with the 1.8% high molecular weight visco. The same one on the cornea. This is an eye prism. So you can see there is no oozing from the side ports, so the view is clear. Once, so this is the position. This is after the position of the head and after the microscope rotation. You can just magnify the view and you can just this is after indentation. You can see with the earbud, you can indent the sclera and visualize the trabeculation. It will also push some blood in the meshwork, which will get the visualization will get better with this indentation. You can see the nice line of the meshwork throughout the angle. Then this is the G1 stent inserted through the side port. Make sure it should not stuck in the side port. You can always refill the visco in the AC as well as on the cornea. So you can see the nicely en-face view, and this is a high mag view. So these are the insertion arches you can see, and once it is inside the meshwork, you can release that. This is the older video actually. This is just to showcase the visualization of the angle and the procedure check of the stents. You can just touch the stent with the tip of the trocar or tip of the injector or tip of the visco cannula. And always do a thorough visco wash before completing the procedure. The blood reflux is a good sign, as I told earlier. So it confirms the placement of the stent in a proper place. So the next video will be of iStent Inject. This was along with the phaco surgery. So starting with the side ports, actually the phaco was done superiorly and the stent was injected temporally. So I have made the side port exactly at maybe 180 degree only. So I don't have to make another side port for my iStent placement. So I'll just skip the part of this phaco. We'll jump to the stent part. So once the phaco is done, after implanting the lens, we'll shift our position to the temporal. Yes. This my chair and microscope shifted to temporally. This is a microscope rotation. So this is a 7-degree rotation and the head rotation. We can deepen the AC with the high molecular weight visco. You can see the size of the side port. It is only that much of width which allows us for the proper placement of the stent. So this is eye prism assets. After the focusing, we'll just so the inject this iStent injector is going inside with the sleeves on. So once we cross the pupil, we retract the sleeve, and then we'll be able to visualize the stents and the trocar. Yes, so this is the iStent Inject W. You can see the central window and this left and right side windows. That is two, and you can see the two stents nicely. Once we are near the trabecular meshwork, you should pierce the meshwork with the tip of the trocar and just touch the flanges to the meshwork, and then you should fire. So here you could see the you could hear the voice of the fire, and in this case I made a mistake that I immediately released the button press button. So luckily, but the stand was in the right place, so it did not get loosened. Otherwise, sometimes it can come with a trocar and it can float in the AC then. So you just always have to press for a few seconds and then you release that thing. And in the with the Inject W, you don't have to make a very dimple much. You can see the reflection on the lens. So this was the earlier videos. So nowadays I have stopped. I'm switching off the OTL lights, so that the reflections can get reduced. Now I'm moving to the 2 to 3 clock hour away from the first stand. In this, the second stand, I release. Yes, I release the press button after few seconds. Now this is the procedure check we are doing. You can, after a few seconds, you can see the oozing from the both the stands, and both the stands are nicely in the trabecular mesh. You can again check with the needle, with the cannula of the visco, whether the stent is loose or it is properly implanted. And once you are confirmed, you can just come out and do the visco wash. So visco wash is a very important, so do not ignore that thing. So this concludes the surgery. So the take-home message is proper case selection, adequate angle visualization, learning proper implantation technique, and management of untoward complications are the key to successful mixed procedure. Always remember, these are the costly surgeries, so there is so much of pressure on the surgeon also to deliver the result they have promised. So proper case selection is very important. Do not over promise the patient about the outcome of the IOP control, and do not try in the very advanced glaucoma with a very high pressure, because again it is a mixed procedure. It is not a trap. You cannot compare the results with the trap. So always do a proper case selection. But at the same time, I can tell you that it can be given as an option, or it can be considered as an armamentarium for the glaucoma surgeon, in which case we don't want to go for any invasive procedures like a trab or a tube in some high risk patients. And you do not want such a very strict IOP control. It is always better to try such procedures. uh, you should keep very much of patience. These surgeries initially, it takes so much of time for the focusing, for the your view frequently gets blurred. Sometimes patient also moves because he is not in the comfortable position of the head. So sometimes they can move here and there. It can blur the our visualization. So the patience is the key. And do not execute procedure without proper visibility. Believe me, I have burned my hands. So after one or two procedures, I was a bit overconfident, and I did it in a hurry, and I lost all my 4 clicks. Then I had to borrow some other injector and put the lens. So always execute procedure when you are 100% confident. Without that, do not go further, uh, and always take care of the trocars. Thank you. Hope I delivered some good points.
Thank you very much for this elaborated session on iStent implantation. So we are running sort of time. I will go directly to Prakhyat sir for his presentation, and then we'll have the QA session in the end, sir. So over to you, Prakhyat sir.
Yes. Uh, Let me just share my screen. Is it visible?
Yes, sir.
Just a second. So good evening, everyone. I am Dr. Prakhyat Roop, and today I'll be speaking about iStent Inject W. And basically, I am going to talk about the Indian scenario. Who should we operate? When should we operate? And why do I choose iStent? So, if we look at the treatment options that we have today for glaucoma surgery, Then we have medications and laser, which are non-interventional, or so to say, minimally interventional. If we talk about laser, they are procedures that can be done in the office, or medications which we can give to the patient. And then there are surgeries for which we take the patient into the OR and we do a major surgery on the eye. Now, with medications, the problem is that adherence to medications post 6 months is just about 53%. And with filtration surgeries, we are taking the risk of, having some complications that can be difficult to manage later and can cause some vision loss. So for myself, the way I process this information is that if I look at medical versus surgical or interventional management, then medical management stands the problems of compliance by the patient. There is a diurnal variation that is definite and can be very, very significant over a long term. So the center where I work, we have patients who have been following up for glaucoma for the past 30 years. And we see that the patients who are diligently putting their medications and are always controlled in IOP are still slowly losing their visual field, slowly losing their precious nerve cells. And that is because they have a diurnal variation which we cannot really control with just medications. That is why we have to keep lower target IOPs in patients who are on medications. The cumulative cost of treatment is huge. If we look at a long term perspective, then the patients do end up spending even more than they would spend with an intervention or a surgery. And of course, there are side effects that come and go, dry eye, MGDs, allergies, and all these things lead to constant morbidity by the patient, constant loss of work, loss of office hours, and basically quality of life. If you look at surgical management, there is minimal diurnal variation. There is a one-time cost. And the surgical risks are majorly perioperative. Sometimes they may be long-term with thin cystic blebs or things like that. So there's a clear divide between choosing a medical management versus a surgical or interventional management. Now, if you look at the Indian scenario, drug compliance is a major issue. That is because patients may not have a very, very stable income, may ignore their problems sometimes, maybe, all sorts of issues with their daily lives where they stop using medications or, fluctuate between their compliances. And that is why you can see that fully compliant patients are just 51%. Diurnal variation is a major reason, according to me, why we should go for interventions early on. Because if you see, it's proven that diurnal variations, if they are more than 11 millimeters of mercury, we are losing visual field much more, if even if we are maintaining the same average IOP. If you look at surgical options, of course, we have trabs, tubes, but they are reserved for severe problems because the risk benefit ratio of doing a trab or a shunt surgery is only justified when we are looking at severe glaucomas, which are intractable or running in high IOP or maximum medications. That is why iStent Inject W is a kind of MIGS that is ideally suited for the moderate glaucoma patient that we have. Because the risk associated with iStent Inject is practically the same as it is with a cataract surgery. So that is why micro-invasive, micro-bypass stenting, plugs that gap between these two radically different approaches of glaucoma management. Now, if we look at the iStent Inject W, and we were talking about over-implantation, so basically this rear flange of the iStent Inject W is made wider. And that basically helps you do the procedure more easily because you are less concerned about over-implantation and kind of more concerned about under implantation, and that has been my experience as well. So basically this is how the procedure runs. You basically visualize the angle, you approach it in a perpendicular manner, like sir said, that your stent or your trocar should not be approaching in a downward, in a landing position. So if you think that you have a aircraft in your hand, then it should not be pointing nose down. It should ideally be pointing just parallel to the iris so that your implant goes straight in perpendicular into the trabecular meshwork. And it's already been proven that it really enhances, clearly shows that the flow of the aqueous channels is enhanced in the region of the implantation. And Kevin Gilman actually demonstrated it on OCT as well, where you can see that the areas where the OCT sections were taken, which were basically right at the stents, and then 500 microns away from each eye stent, showed the patency of the Schlem's canal in those areas. So basically, we are essentially opening up this channel, and even if we are implanting in the nasal area only, we can see that there is some opening even in the nasal portion of the Schlem's canal. So basically, it's a 360-degree opening of the Schlem's canal that happens because of this bypass. So, if you look at the surgical technique, you can, it's very simple. Sir demonstrated it very, very well. In fact, I am amazed that he does it with practically no tilt on the microscope. So, it's really difficult to, stabilize the prism and inject. But if we ideally have a microscope, I'm using like a 822. So it has a tilt up to 40 degrees and it's a motorized tilt. So we've set it, if you can see this mark, it's set at 31 degrees. So we tilt it to 31 degrees and we tilt the patient's head by 25 degrees. So 25 degrees angle is this, 35 degrees angle is this, and altogether it becomes 55 to 60 degrees. Now we need to avoid a parallax. That is, I'll show in my video subsequently when we can have a parallax, and we have to aim for an on-fast view like Sir said. So looking at the surgical technique, I usually have done all of the eye stents that I've done have been in a pseudophakic eye. Most of them are combined surgeries that I do. So basically, we take out the lens, we do a clear lens exchange for a patient who is around 50 years of age, so that we don't have to go in for another surgery. And that is usually my approach. So, like Sir said, we come into the position of the on-fast view of the angle, and then I actually exploit the self-sustaining part of this glaucose eye prism actually. So I really just support the prism with just one finger. So this is the visualization of the angle, and I can perfectly visualize the pigmented portion of the trabecular meshwork. And I want to inject right at the posterior or the pigmented trabecular meshwork. So basically, I aim to inject, or the tip of my trocar is actually in the same line or is parallel to the anterior trabecular meshwork, because the trocar is actually within the sleeve. So if you look at the jacket or the covering all around, then that is actually pointing at the anterior trabecular meshwork, so that my trocar pierces the pigmented trabecular meshwork. So so basically, we tell initially what we should be aiming for is to go for the anterior trabecular meshwork. By default, we are going to land in the pigmented portion. And as you can see, we go 2 clock hours away, and again we have the on-fast view. If if we have the on fast view, you are able to actually see this whole of the stent really on the face. So that is the ideal position to be actually be able to visualize the stent. And as we already discussed, sir has beautifully shown, ooze of blood is actually a good sign, which tells you that there is a backflow, so you are directly connected to the Schrem's canal and the aqueous veins. So that is the standard surgical technique that I would say. Now, there are a few challenges in Indian eyes. Sometimes we have a clearly pigmented line, which is very good. But Indians, and in India, the kind of ethnicities, or so to say, the variations of the iris colors is so much that we can encounter almost all sorts of angles when we are doing the surgery. So this is another case where you can see that I am really struggling to identify where exactly is the angle. And these are the two lines that I can identify. Now I'm confused which one of them is the trabecular meshwork. In most of the cases where there is no pigmentation whatsoever, and you have a deep angle like this one, where you can see all these iris processes which are almost posteriorly inserted, in more cases than not, the the trabecular meshwork is actually the more anterior line. So basically, this is the ciliary body bands which are being exposed, and actually this is the scleral spur, and this part where my cursor is right now is the trabecular meshwork. Now, why am I so sure about it? The reason is that there is some ooze of heme blood here. And the other reason is that I did a pre-operative gonioscopy myself. So I believe that a four prism gonioscopy, a four lens gonioscopy, which sees the temporal and the nasal angles, is actually very, very good. If you do it pre-operatively, you know the configuration of the angle much better, because there you can make a slit and see exactly how the trabecular meshwork of this patient looks like. So that is a really good thing that helps me in my cases. So a gentle dimple and the click is done. Like sir said, that we should not uh, immediately release the trigger, because it kind of causes a little bit of a vibration. Now, that is the second stent that goes in, and that is the end of procedure. Now, since I did not have any ooze of blood, actually I go back, and when I'm aspirating the visco, I confirm that there is some ooze, and then there is another sign which we can see, which is the blanching of the vessels in the nasal part of the limbus. So if you see now, I am pressurizing the AC, and you will see some blanching in the nasal part. So you will see the color change suddenly. Just now it changed, and then again, if I release the pressure, it will come back. So let me just show that again. So if you look at this nasal part of the limbus, I'm going to magnify to that area just to check. So it is now, right now it is looking little bit red, and suddenly as I increase the pressure, it blanches. So the vessels actually, there is a gush of aqueous or BSS into those vessels, and that pressure basically causes the blanching, which confirms that I have communicated directly to that channel. Now, going ahead, you can face some complications, and I have had my fair share of complications during this surgery. So since I am a cataract, cornea and refractive surgeon, and I do combined procedures more than just glaucoma trabs, so basically my experience with MIGS is very limited. It is basically just KDB and iStent, and I'll talk about more why I err towards iStent whenever possible. So here I go ahead and I implant, and as I come back, I see that my implant has actually gone deeper. It's actually in the ciliary body band, or the scleral spur. So you can see the red line is clearly above the stent. So if you can see now also, it's clearly above the stent. So there is nothing to fret here. I go ahead and do my second implant, and I rectify my mistake of going on fast and going in the trabecular meshwork. So I do my second implant, and as I come back, I can see that the ooze is there, but the stent was under implanted and it comes off as I come back. Now, as you can see, my hand is a little bit shaky because I know that I have to reimplant one stent. But then I go ahead and I can see the stent already clearly. So I rethread it right away. So basically, I go ahead with the same trocar and kind of just manipulate it and just rethread it right in situ. So I have rethreaded the stent right here. I check that it is not loose and it is threaded onto my trocar. And once that is done, I just come out. I basically pull the sleeve again, come out, put viscoelastic again, so that I can visualize that area clearly, because that was my desired area of implantation, because it had thicker trabecular meshwork. So if you see that that area has a thicker trabecular meshwork, so I wanted to implant there only. And then I go ahead and implant again the same stent which I had threaded, and it goes in and I can see the ooze also. And once I confirm that the stent is in situ, I check for the procedure confirmation. I go ahead, take out my deeper implanted stent, basically posterior implanted stent, and rethread it outside. So I go ahead and rethread it, and then I have now one click left with which I'm going to implant this one. So this is how you can easily manage by rethreading and re-injecting. Now let's look at why you can have problems with too much ooze of blood also. So here you see that there is a lot of blood that has come out, and all of this blood has come out because I have done a combined surgery. I have taken out the cataract, and the patient is a high myope. So the iris has gone too posteriorly. So basically these are micro injuries, micro iris disinsertions that have caused a lot of blood to actually ooze at the root of the iris. I clear that blood out, and then I go ahead and do my first implant. Now you can see that there's a lot of ooze of blood. I have not pressurized the anterior chamber too much because it was going to posterior, and that was causing injury to the root of the iris. So I go ahead, inject some OVD and confirm that my stent is in the right place. And then I do a media clearing first. So I go ahead and actually clear out some amount of blood so that I can have a clear view. I want absolutely no heme in the AC because I want a clear, crystal clear view of the angle. So I do the same step once again, take out all of the OVD, inject OVD again, and here you see that I again have a pristine view of the Schlem's canal, basically the trabecular meshwork. And then I dimple it and inject it, and that is the end of the procedure. I again confirm by putting OVD, and of course the ooze actually shows me everything. So I have done about 15 implants by now, and I have the data for all of them. Here I'm sharing the first 10 cases, basically 11 cases. And you can see that my choice of deciding which patient I'm going to do is really not dependent on the cupping, which is something which we are told to do. My choice is basically dependent on the target IOP and on what drugs the patient is right now. And also how sinister is the glaucoma there. So if a patient has been managed on 4 drugs with an IOP ranging in 20 for the past 6 or 7 years, and his visual field has also not deteriorated, I know that my target IOP is just 16. And that I can easily achieve with an iStent. So basically, the choice of choosing iStent actually depends on the uh, degree of blockage of Schlem's canal, or so to say, what anatomical damage are you expecting to be there in the Schlem's canal? So, uh, in my practice, I see that there are a lot of compliance issues, chronic dry eye and MGT, slow decline in RNFL due to diurnal variations, which is frequently missed on short-term follow-ups. And I see that now that I am doing more and more OCTs, I detect pre-perimetric glaucomas, which is why in our practice, at least at our center, we have a lot of young patients who are on glaucoma medications. So that leads to a lot of concerns with compliance and side effects of drugs in the long term. And there iStent fits my practice comfortably. Now, why I prefer iStent over other MIGS is because one, there is a long-term efficacy data that is available. Two, it is logically, it appeals to my mind that if I have opened the Schlem's canal through the passage of aqueous itself, then there is no reason why it would close down in future unless that flow of aqueous itself stops. And that is why I expect that if an iStent is functioning well in 2 years, then it is functioning well at 10 years also, and it is most likely to function well in the long term as well. Now, I'm not talking about need of drugs later. The overall glaucoma situation may precipitate to an extent where we might need to start a drug, but the stent itself will not stop functioning. And it has no safety concerns and minimal morbidity, no additional downtime compared to a cataract surgery. So that is why I prefer doing eye stents more. Thank you.
Thank you very much, Dr. Prakhyat and Dr. Kaivan sir. Both has given an excellent presentation on the experiences what they have gone through of their learning in initial and then coming out of those challenges situations and finding out the right patient selection for this. So, sir, we have a few questions here in our chat box. I'm just going to read out for you, and both of you can give the suggestions on that part. The first is Dr. Meeraj Pokhriyal has asked, what are the long-term effect on children and in special cases like pseudo exfoliation one?
Okay, I'll go first. So
Yeah,
basically, pseudo exfoliation is a good case. Pseudo exfoliation, steroid induced, but in pseudo X, you have to look at the angle configuration. If pseudo exfoliation is open angle, you can see the trabecular meshwork clearly. You can go ahead with an iStent and it will work well. Pigment dispersion, steroid induced glaucoma, very good cases to do uh, this surgery. I have personally not implanted in a juvenile open angle glaucoma. And there is another indication which nobody talks about, which is a significant indication in India. We have a lot of patients who undergo early iridotomies. Now that a lot of surgeons are doing gonioscopy in the OPD, we have started doing more iridotomies even before angle changes start. So basically, primary angle closure suspects and primary angle closures undergo PIs, and then later they need glaucoma medications. Now, we have implanted actually 4 stents in these patients, and they have all worked really well. And the reason I believe that has worked is because logically, the angle closure configuration of the Schlem's canal and the subsequent pathways happens only when there is a chronic goniosynovial formation. So basically, if you prevent that, you are essentially preventing the anatomical changes that are going to happen in the next 10 years. And so essentially, if you have the access to trabecular meshwork, even in narrow angles or erstwhile narrow angles, you can actually do pretty well with an iStent.
great, sir. Sir, even it has asked, like Dr. Madhu has given a question, like, is it always recommended to use two eye stent in eye?
So basically, ma'am, it comes two iStents come in one stent. So it is recommended that you use both of them because you are expected that you will at least address 5 or 6 collector channels directly by having two stents 2 clock hours away. So that is basically the rationale behind them giving two stents to us, that we can inject them some degrees apart, and that is going to open up the whole of the Schlem's canal in that area.
Yeah. I think on this question, Kaivan sir can give the more uh, input on that, sir. Since he has sir has used a generation one where sir has used only one L-shaped inject device has implanted, and now the stents has come in the latest version. So it's again depends on the what model we are using it. So currently that a single one model is not available in the global as well as in India. So it comes with the two stents in single device, and it has to implanted in a single eye with the two stents in 2 o'clock apart to each other.
Yeah, basically I have used G1, G2, G3, all Inject W, everything. So the thing is, G1 usually, even I had implanted in the phakic eyes also 2 or 3 stents, not in the stand as a standalone procedure, not in the combined. But the thing is, only one stent, the efficacy of only one stent is not that much, uh, and the cost also does not justify for the pressure reduction. So usually, but the two stents definitely do a better IOP control, and most of the patients till date are drug free. I have follow up of maybe 1.5 to 2 years now. uh, Only one patient did not go well as expected, but otherwise all the stents which have already been implanted, they are working nicely. So the two stents make sense. It usually we can expect maybe 30 to 35% or sometimes even 40% IOP reduction also. the idea of implanting the keeping this iStent or any mix as an armamentarium, apart from this trab and tubes in the advanced glaucoma, I can share one of my patient who was a very high myop, 70 years old gentleman with one eye was operated for the trab elsewhere, very bad cystic bleb, and had developed once blebitis also. Luckily, we could save without end of. We could control the infection. So on the other eye, we were very reluctant on, and he was already operated for RD also, detachment surgery also. So there was the congenital was also very bad with the buccal in situ. So in these cases, we want to avoid any invasive procedure for the sake of any dreaded complications, for to prevent the complications. So in this case, we implanted actually iStent, and this was my actually first case. So he was already on 4 AGM with an advanced cupping. So luckily, right now he is only on 1 AGM with a good IOP control, maybe 12 or 13, and he is on 2 years follow-up right now. So we always should keep in mind and do some proper case selection, and always keep the patient informed about all the possibilities and all the complications and all the outcomes. So patient also be ready for this.
Sir, again, there is one more question. Like, is it always necessary to combine with cataract surgery?
No, usually it is not like that. But if there is a cataract, better you knock it off along with these stents. It will give you a better outcome, IOP wise also, and in the future also you don't have to do a separate surgery. Plus, it will allow the angles also to be a bit more favorable for the procedure of the mix. Sometimes in the phakic eyes, the trocar and everything, that can be a bit challenging to handle gently, avoiding the injuries to the surrounding structure. So if the cataract is already knocked off, then it is very easy for the angle procedure to be done.
That's great, sir. There are many questions have shared here, and even Dr. Prakhyat has also answered one question like, have you used the iStent in angle closure? And since he has given a input on that also, sir, the basic question what the initial participants faced, like what kind of the selection and what kind of the patient should select in the initial cases to get the real outcome or the result. So what is your opinion on that, sir? You can share.
So ideally, if the patient is on one or two drugs, not a very advanced glaucoma, nice clean angles, and no other ocular comorbidities, then those are the, and if it is a pseudophakic eye, so if you want to go for a standalone procedure, then those are the good cases. Yeah, even the cataract is there, and if you want to go for a combined, that is also a good case. But you should. I was maybe I was a bit convinced with the Prakhyat's data also, that even in the point 0.8 cup, he could bring down the IOP with the two stents and making the patient drug free, because the pressure was not with the 4 AGM, the pressure was maybe around 820. So that drugs are working, because the meshwork is still not get that much of fibrosis is not there. So we can expect the stents or any mixed angle place procedure to work in such cases, and at least we can even if at least if we can bring down the medicine to 70-80% of whatever he is using right now, that will be a very the compliance will definitely get improved. Patients the life comfort will definitely get better, and we can avoid the complications of this invasive procedures also.
In fact, sir, add to that, I'll share an experience. I had a patient who had zero point 0.9 cupping in both eyes, and he had thin corneas. And he was on glaucoma medications for the last 15 years. And he was maintaining a pressure of 8 to 10 for the last 15 years with a zero point 0.9 cupping. And he needed cataract surgery basically. So when he came to me, I said that, we should do something about your glaucoma also, because, and he was a very aware patient. In fact, he was not formally educated also, but he was very aware about his glaucoma. So he went ahead with the iStent, and his pressure, he was on 4 medications. He had side effects. He was in fact on Ripatec. So basically, he had a lot of congestion every day. He was bearing with that and doing everything. When we actually did iStent for him, he still remained at 8 without any drugs. So basically, he had a functional trabecular meshwork or functional Schlemm's canal all along. He was maintaining that IOP on those drugs for that many years. His cupping at point 0.9 had maintained at point 0.9 for such a long time. So that means that the disease pathology in his eye is not that sinister. And if we are combining it with a cataract surgery, he's a good candidate who can benefit because he's a 50-year-old gentleman. He has to live another 20, 25 years. So we should look at that aspect as well.
And
And sir,
sir, there is
there's another question. They've asked, would you put, how many stents would you put in case where a failed glaucoma drainage device implant? So, so here I think my input would be that the glaucoma drainage device is failing because of fibrosis, most likely. So it's not an indication where you can go ahead with a iStent. Baki, Kaivan sir will elaborate on
Yeah,
it.
again, the same logic. If the pressure with the drops, if we are not able to control, then only we someone had put the drainage device. So that means that the meshwork is not actually functioning. So I don't think that any angle procedure will help a lot in such patients. Better to go for a second tube and or a trab, nasal trab, if the conjunctiva allows. In fact, I am a big fan of trab more than the GDD. Whenever I find any 3-4 o'clock hour of conjunctiva, good conjunctiva, undisturbed. So I give a trial of trap first. The other indication of eye stent in such cases, like in some advance or if you want to delay the invasive procedures, is that at least if the stent can reduce the drops to maybe 60-70%, so that the inflammation, the conjunctival inflammation will definitely on the long run will get reduced, and that will help in the future invasive procedures, so that the fibrosis, trap fibrosis, will definitely be very less compared to what the if you're touching the patient with the inflamed conjunctiva. In those cases, the traps are like they fibrose very fast. So in such cases, it's like an intermediate thing, that if you want to delay the trap, in between you do something, you make the conjunctiva better or less inflamed, so that in the future you can do an invasive procedure more successfully.
Yeah. Sir, I think there in the same line, there is a one question from Dr. Swati. She has given like, can we go for iStent in post phacotrab eye on two drugs?
Why not? We can do, but only thing is that you should just see whether further you want to enter the eye just to implant the stent, or if the is it really indicated. If it is under well controlled, if there are no side effects, patient is compliant, then we don't go inside the eye too frequently. If the patient is non-compliant, patient cannot tolerate the drops, and if you want to just bring down the drops, then definitely it's an option.
Sir, since we have discussed about the patient selection and getting the outcomes and target IOP, uh, in the same line, there is a question from Dr. Madhu. Is there any specific post-op treatment? Do they need to be in meiotic post-op, sir?
I don't give miotics. Actually, I do give cycloplegics for a week, uh,
Okay.
just to make sure that it will basically in the fake pseudophakic eye, cycloplegic will just keep the inflammation part under control, as well as it will stretch the ciliary muscles, so the meshwork will can get opened up and the flow can get started maybe uh, as early period. Uh, the thing post-op treatment, yes. So in
Yeah.
the post-op, see, I have seen a few of the patients are of the mix. Sometimes they get bad steroid response. Usually I have shifted to from the prednisolone or dexamethasone. I have shifted to the lotiped 1% now. Uh, that actually works well because these are very micro-invasive surgeries, so we don't expect much inflammation. because we have not touched, we have not incised anything, we have not touched the iris, so you don't expect much inflammation. So that you have the option that you can avoid the higher strength steroids like prednisone or dexamethasone, and you can shift to the lotipred 1%, so that you can give as the routine whatever you are giving in the phaco, the same process, the same protocol you can follow. But I do give cycloblogics for a week at least, then I stop it.
Dr.
You are
Prakhyat, what's your post-op management actually? How do you manage your patient in a different types of eye
so
stent which you are selecting the patient?
I 100% agree with sir. Uh, in fact, the usual course is that we continue the glaucoma medication for 2 days, and then we ask the patient to come after 2 days. We stop the glaucoma medications altogether, or probably reduce them down to one drug. And at 10 days, I see that the patient's IOP is well controlled, and he does not need any drugs. And then when he comes at 4 weeks, sometimes I see that the IOP begins to climb up. So I am seeing a steroid response here. And it's a typical situation, because if we give steroid for 1 month, then we expect that after 3 weeks, the IOP will begin to spike. So basically, my regime is that I have shortened my steroid duration to 15 days. And so what happens is that every 4 days, it is going down from 6 times to zero at 15. So that way, it has come down. But I have not really shifted to loteprednol. I don't give myotics. Only in one case did I give myotics. That was in the case that I was discussing, though both sisters who had a primary angle closure. One was primary angle closure suspect, one was primary angle closure. 20 years back, they had both undergone a YAC PI at this very center. And at that time, they didn't need medications, but they had later developed rising IOPs, and then they were started on medications around 8 years back. So when we needed to do their cataract surgeries, we went ahead with an iStent along with it. And for the first 10 days, I gave them Pilo, just to like not let the angle crowd, or probably the pigment not go into the stent. That was the logic basically that I thought.
I think we have any other question from, yeah, sir. I think there is one more question. Yeah, sir has replied on that mathematics. Yeah. So I think since it's a 9:42, and I think it's going to be a dinner time for everyone, and it's a really great discussion we have today, and the audience is very curious to ask about this procedure and the post-op management, whereas and the different types of patient, whether we can go ahead with the surgery or not. So it was really a great discussion, learning and discussing from our both speakers who has implanted the generation 1 as well as the generation 2 and the generation G2W, and the steps how to follow for the eye stent implants, the importance of visualization and the holding of device perpendicular. The both of the speaker has mentioned the importance of the visualization and the device perpendicular implantation, and the spacing is really very much required. So thank you, Dr. Kaivan sir and Dr. Prakhyat sir, for this excellent presentation and sharing the experiences. I hope our audience has learned many things from both of you, and thank you all. Good night and have a nice day. So,
I just have a comment for Dr. Prakhyat.
sure, sir.
The recording of that rethreading was excellent actually.
Oh
So
yeah, yes, sir. I must say,
so
it's
in
in a high itself.
such a scenario, it is difficult to keep calm and
Yes.
start continue recording of your surgery. It is
It has happened with me. Like this was an easier thing. I have had complications much bigger than this during my
uh,
course. So
I had to I told no, I finished all the 4 clicks in one patient, and I was
yes.
still one stent short of implanting. Then I had to implant a G1 on from my pocket in that case initially.
So I think, sir, this can be one learning things. Whomsoever is going to start as it is a new surgery, there will be a learning curve, sir. So we
Yes.
have to be patient, and we have to see that what we can do it. And in a few cases, initially 2, 3, 4 cases, it will be a learning uh, for you. But after these 3, 4 cases, you will be able to manage all the situations what it can be opposite to your surgery actually. So we have to be calm, as sir has mentioned definitely in his PPT, to be calm and relaxed to implant this eye stent. And Dr. Prakhyat has shown in a video that how you can be easily rethread in the eye itself and you can implant. So this is the point we can consider for the new implanters whomsoever is going to be there. So thank you all. Good night, sir.
Yeah.
Thank
Good
you.
night, everyone.
Good night.
Good night,
Good
Thank
sir.
you
night.
and happy weekend. Bye.
Thank
Thanks.
you, sir. Happy weekend.